Hello everybody. Today we're going to be talking about the Petrous Apex. We'll briefly review the normal anatomy and consider normal variants. It's important to recognize the don't touch lesions, meaning lesions that don't need biopsy or surgery. In order to determine what a mass is, we want to describe it properly, its exact location, and what structures it involves. Then we'll ask, is it an expansile mass, and what is it doing to the bone? Here are two CT images from a couple different patients that we'll discuss more of later. The Petrous apex is the medial part of the temporal bone, which articulates with the sphenoid and the occipital bones. It is bound by the inner ear laterally, by the petroclival fissure medially, and the petrosphenoidal fissure anteriorly. The Petrous carotid canal is in the anterior aspect of the Petrous apex. The Petrous apex contains Dorello's canal, which contains the abducens nerve. And so let's look at the range of lesions that we're going to be looking at throughout this lecture. In the top row I have the don't touch lesions, and these are going to be pneumatization of the Petrous apex, this non-expansile lesion on the left that we'll talk about more, again non-expansile lesion on the right with a narrow zone of transition, almost looks like normal trabeculation of bone, and then now the more expansile and aggressive lesions, expansile lesion of the left Petrous apex, expansile lesion with a broader zone of transition and focal cortical breakthrough, lobulated mass with some interesting MRI characteristics, lytic lesion of bone with a broader zone of transition again, focal cortical breakthrough, a permeative sclerotic lesion of bone with associated dural enhancement and maybe a dural mass, and a large lesion that involves not only the Petrous apex but a large portion of the central skull base. So first, pneumatization of the sphenoid apex, which is highly variable and can be asymmetric. If only one side is pneumatized, normal fat on the opposite side could appear as a lesion. Again, this is a common finding, and the presence of this pneumatization means that if the mastoid becomes infected, the Petrous apex can also become infected, which results in additional symptoms involving the more central skull base. In the next case, we have pneumatization of the Petrous apex on the right and an abnormal non-expansile lesion of bone, which is well circumscribed in the left Petrous apex. On MRI, it demonstrates T1 hyperintensity, which suppresses with fat suppression. On T2, it's hyperintense as well. And this is arrested pneumatization in the Petrous apex. This is a developmental finding and is a don't touch lesion. Here we have on the right the non-expansile lesion of bone involving the right Petrous apex, which demonstrates a almost normal trabecular pattern. On MRI, it demonstrates hyperintensity on T2 weighted sequence and no hyperintensity on T1 and no abnormal enhancement. This is trapped fluid within the Petrous apex. This is also a don't touch lesion without pathologic significance, but is a good normal variant to know about. Again, the keys are here, it's non-expansile nature. In contradistinction to that, we have an expansile lesion of bone involving the left Petrous apex seen on CT. This will require an MRI for further characterization, which was done, and we see hyperintensity on the T1 weighted sequence, which does not suppress on fat suppression and does not demonstrate post-contrast enhancement because of its intrinsic T1 shortening. Relatively low signal on T2 and lack of restricted diffusion. These are findings that are characteristic of a cholesterol granuloma, specifically the hyperintensity on T1. Very few lesions are going to be hyperintense on T1 and not fat suppressed, and its expansile nature. This is also a classic location for this lesion. Now let's get into more of the aggressive lesions of bone of the Petrous apex. On the right, we have a destructive lesion of bone with a broad zone of transition, cortical disruption, lack of internal matrix, centered in the region of the Petrous Apex, and of note, probably involving the petroclival fissure. On MRI, we see a T1 hypointense lesion, which is hyperintense on T2 and enhances without significant restricted diffusion. And while this can be one of several aggressive lesions that we'll continue to talk about, this happens to be a chondrosarcoma, with one of the important features being its relative T2 hyperintensity, its very destructive nature, and its involvement of a synchondrosis. Here we see an expansile lesion of bone centered within the right petrous apex, involving the petroclival fissure. So this is also a good candidate for chondrosarcoma. But this lesion also involves the clivus. There's actually a sclerotic component involving the clivus with a broad zone of transition, and this happens to be a chordoma. And let's look at the MRI features, which can help point us in that direction as well. Chordomas tend to have a lacy appearance, or some people describe it as a honeycomb appearance, with different cavities circumscribed by hypointensity on post-contrast imaging and T2 weighted imaging. So T2, lobulated, irregular mass, T1, hypointense, post-contrast enhancement with regions of non-enhancement, sclerosis of the clivus, lack of restricted diffusion, chordoma. Here we have a lytic lesion of bone involving the left petrous apex with a broad zone of transition without much associated mass. There's also pacification of the left mastoid air cells, and not pictured there's swelling overlying the left mastoid. And this is a patient with Petrous apicitis. This type of infection can result in an abducens nerve palsy, which would be secondary to the involvement of the abducens nerve as it passes through Dorello's canal. It can also cause retroorbital pain, which would be in the cutaneous distribution of the frontal and maxillary divisions of the trigeminal nerve. This is due to extension of inflammation into Meckel's cave, and that combination of symptoms is known as Gretton-Agos syndrome. It's also important to remember that infections like this can be very similar in imaging appearance to malignancy, and you're going to want to know if there's any clinical signs of infection, fever, leukocytosis, and know that there is overlap between infection and neoplasm. A different case, sclerotic lesion of bone with a broad zone of transition, demonstrating hyperostosis and periostitis, with associated, turns out to be trapped fluid within the right petrous apex, associated with thick dural enhancement and extraaxial mass. This turns out to be a meningioma, and our hints are the permeative sclerosis of bone and the associated dural findings and dural mass. In our next case, we have a large mass involving the right petrous apex and the central skull base, the clivus, which is relatively low in intensity on T1 weighted imaging and heterogeneous in attenuation and heterogeneous in signal on the T2 weighted sequence, and demonstrates fairly homogeneous post-contrast enhancement with mass effect on the pons and midbrain. We also want to describe the encasement of the carotid arteries. We can question ourselves as to whether these are formation of a chondroid matrix or formation of some other bone elements, but the picture is not perfect for that. And whenever we see a lesion that involves the central skull base, we also want to think about where is the pituitary. And this is that same patient, sagittal T1, coronal T1 post-contrast with fast saturation. And we see that we can't find the pituitary. And with an absence of a normal pituitary, the top of our list with this kind of mass has to be a macroadenoma, and that's what this is. The other masses that can occur here, including a chordoma, chondrosarcoma, they would displace the pituitary. So our lesson here is to always confirm the presence of a normal pituitary. Here's another lytic lesion of bone involving the left petrous apex, hypointense on T1, fairly intermediate to high on T2, which demonstrates post-contrast enhancement and extends into the Meckel's cave on the left. Here's a normal Meckel's cave on the right, and this turns out to be a metastatic lesion from breast cancer. The other entity we want to consider is this one. And again, we have a lytic lesion of bone within the right petrous apex involving the central skull base with a broad zone of transition with cortical breakthrough. On coronal imaging, we can see this well. And we have MRI showing the same mass, hypointense on T1, actually crossing midline, abnormality involved in the nasopharynx on the right, which is very important to talk about, and the same findings on T2. This happens to be a squamous cancer with direct spread from the nasopharynx. Nasopharyngeal carcinoma can also have a very similar appearance. Notice there is obstruction on the right of the eustachian tube, which results in this right mastoid effusion. Another takeaway from this case is whenever you have a mastoid effusion, look at the nasopharynx for a mass. And here's a relatively uncommon but important entity to think about: ectasia or aneurysms of the parotid, which are coursing along the anterior aspect of the Petrous apex. Now let's summarize what we talked about. We have these non-expansile, essentially normal variants, pneumatization of the Petrous apex, which can be symmetric and highly variable. We had arrested pneumatization of the left Petrous apex, trapped fluid, an expansile lesion of bone, which was T1 hyperintense, consistent with a cholesterol granuloma, more aggressive mass involving the petroclival fissure, which was a chondrosarcoma, this lobulated mass involving the central clivus with this honeycomb-like appearance, a chordoma, aggressive lesion in patient with symptoms of infection, Petrous apicitis, permanent sclerotic lesion of bone, a meningioma, mass involving the sella, where we could not differentiate the presence of the pituitary, and this would be a macroadenoma. So remember the normal anatomy, adjacent structures, and really figure out what is the origin of any lesion that you're seeing. Remember normal variants, the don't touch lesions, and describe a mass as being expansile, or is there bone destruction, is there bone formation. Thank you very much for your time.